Our first keynote is Mr. Bill Marella. Bill is Director of Patient Safety Reporting Programs for the ECRI Institute, and he works also as the Program Director for the Pennsylvania State Patient Safety Authority's statewide adverse event and near-miss reporting system. In addition to publishing the authority's quarterly online journal, he has published articles in the Journal of Patient Safety, the Joint Commission Journal of Quality and Patient Safety, and many others. And he's also very involved on a national level on various committees and commissions. So we're really pleased to have Bill here this morning to start us off. Let's give him a warm round of applause.
Okay, thanks. Good morning. My name is Bill Marella. I'm from ECRI Institute. I'd like to thank Tony for inviting me to talk to you all this morning. And before we get to talking about the magic of health IT, and I'm excited to look at the agenda for the rest of the day's program, I wanted to spend a little time talking about patient safety issues. So some of the things that we're seeing that are going wrong and opportunities for improvement with health IT. So the title that I chose for this was Patient Safety and Health IT in the Era of Healthcare Reform. It's kind of a heady title, right? And it begs a question, which is, what healthcare reform? So, we know now that the health reform law is constitutional, and we'll have to see, though, if it stands after the election. But the truth is that the wave of integration and consolidation that we're seeing in the healthcare system now was started before the health reform law. So we'll have to see how that plays out. But one thing is pretty clear, is that healthcare reform is going to fail without support of health IT. People's dream for this is that information is going to flow seamlessly across care settings. The video that Tony showed, I think, is characteristic of that. ACOs and medical homes, for example, are going to require that we're able to integrate data in a way that really has not been done successfully until now. What we're seeing in the data that my organization collects and some of the data that's going to FDA now is looking at some of the unintended consequences of health IT. As we're spending the ARA stimulus money implementing health IT and the explosive growth in projects that we've seen over the past couple of years, we're starting to see some adverse events, including some patient deaths associated with problems with health IT. So I want to make clear that I am not an IT basher by any means. I love this stuff as much as you do, but I think it'll do us all good and be in the benefit of the healthcare system if we pay some attention to sort of the negative consequences and not just always kind of focus on the cutting edge. So the $19 billion in incentives for EHR adoption, I don't need to tell you about that. You're all familiar with it. But the cynical way of looking at incentives is to call them bribes. Why do we have to bribe hospitals and physicians to adopt the EHR? That's the cynical way of viewing it. But I wanted to say that when you put that in context, we waste $750 billion every year in the healthcare system in unnecessary treatments that are not effective, in tests that have to get repeated because information's not flowing between care settings, excessive administrative costs, workflow inefficiencies, and these are the things that you're all working on. IT has a role in fixing all of these problems. So when you put the $19 billion of the Recovery Act in context, it's a minor investment in infrastructure that we desperately need. So what I wanted to talk to you about this morning are a couple things. Just quickly address where we are on EHR adoption, and then turn quickly to the clinical literature to look at the evidence behind whether or not EHR implementation makes for safer healthcare. My organization, both the Patient Safety Authority and ECRI Institute, as well as FDA, are collecting information on the adverse effects or the unintended consequences of health IT implementation, and I'll share some of that data with you, and then finish up with talking about how we can evaluate the safety of health IT. So you're all familiar with the HIMSS adoption model. These are the latest statistics from HIMSS Analytics, which they sent me last week to use here today. And even with the financial incentives, even with the explosion in health IT investment that we've seen, the majority of hospitals, while they've achieved level 3 on the HIMSS scale, we still have only 10% of hospitals that are sort of at the top end in stages 6 and 7, and having adopted complete clinical decision support, which includes reporting back to clinicians information about the care they're providing. That's a kind of feedback that clinicians, when they do get it, they tend not to trust until it's validated. And I think if we can get there, we will see meaningful improvement and significant reduction in the variation in the outcomes of care. So any of you who have ever been to a conference or a workshop that talked about patient safety, you know that it is obligatory to start with the IOM report from 1999 to err is human. Sort of old news now. But what I'm going to talk to you about a little bit is the other IOM report. This is one that just came out this year, and it's specifically focused on health IT and patient safety. One of the things that this report comes out with that I think is good for you is it affirms the clinical benefit of adoption of CPOE in terms of medication safety. So the jury is in, or the verdict is in rather, in terms of whether health IT has a positive effect on medication safety. We know that it does. However, there's limited generalizability from that to other forms of health IT and these ancillary systems. And there's so much integration work that's still yet to be done. I don't know that we can say yet whether there is an overall EHR effect that goes beyond medication safety. And I'll talk about some of the evidence behind that in a minute. While some studies suggest improvements in safety, a lot of others have found no effect. And as I said, we are starting to see some adverse events being reported. What we don't know really is what's the magnitude of those problems. And there are a couple of reasons for those knowledge gaps. Among those are absence of reliable and valid safety measures. What are we talking about? What are we measuring when we talk about the safety of health IT? There's no central repository of adverse event and near-miss reports. This is one of the criticisms that the IOM committee made, though there are organizations like mine that are collecting some of this data now. So I think we have an infrastructure in place for this. Also, I don't need to tell you about the uniqueness of health IT implementations. If you've seen one, you've seen one. And one of the other issues that the IOM has uncovered is that a lot of hospitals and health systems are saying that there are contractual barriers in their agreements with the EHR vendors that prohibit free sharing of information. The vendors, in some cases, dispute this and say that there is no restriction in their contracts like this, but the fact is the hospitals are interpreting some of their contractual language as prohibiting them from doing things like sharing screenshots with FDA or organizations like ECRI when they're reporting problems. So that's either a real or a perceived barrier, but one that needs to be addressed. Some of the recommendations that the IOM committee makes, it requests that HHS start an active surveillance plan for the safety of health IT, and that it should ensure that vendors support the free sharing of information, both hazard and problem information, but also user experience, sort of the softer stuff of interacting with health IT. The committee also recommends that HIT vendors publicly register products with ONC. I think to a large extent that's already going on. I mean, we've got the certification program. There are now thousands of certified health IT products, which sort of begs the question, all right, if you set the bar for a certification program so low that everybody gets in, what's the benefit of the certification? The other topic they bring up is that HHS should establish a mechanism for people to report health IT-related deaths, serious injuries, and unsafe conditions. They also call for an independent agency to investigate health IT problems. And the model that they reference is the NTSB model. So when a plane crashes in the United States, or actually probably anywhere in the world, within 24 hours there's an NTSB team on the ground investigating this. Personally, our view is that these investigations will be more effective if they're tied into the existing risk management and patient safety infrastructure already within your institutions. So I don't know that a separate agency is really what's required. And they also talk about HHS monitoring and reporting on the progress in safety of health IT annually, and that if progress is not sufficient, they should be prepared to regulate. I think in the intervening months since this report was released, the writing is sort of on the wall, and I think regulation is coming. I think that's a done deal. The open question is how strict and how intrusive will the regulation be? I think that remains to be seen, and they're hoping that the industry will take efforts to reform itself and not have to require regulation by FDA. Though officials from FDA have stated that they feel they already have the authority in their existing authorization to treat health IT and the EHR as a medical device. They also call for research on, again, as I mentioned, this softer stuff of interacting with the EHR and focus on human factors and user-centered design principles. So I want to turn now to the clinical literature and look at some of the evidence behind both the benefits and the negative effects of health IT. So e-prescribing, this is one area where there have been a lot of systematic reviews done. And I tend, being an evidence-based medicine fan, I tend to give more weight to systematic reviews than I do individual studies for a variety of reasons. Most being, with systematic reviews, you can have greater confidence in being able to generalize beyond the setting of a single study, which many studies are done in an individual hospital. Unfortunately, the IOM says that there's a lot of variability in the methods used in the systematic reviews looking at medication safety. But in general, the findings are positive with respect to ADEs and medication errors, and that CPOE and e-prescribing make that process safer. Though the evidence is much more compelling in the adult population than in pediatrics, where you have to deal with weight-based dosing, and there's a lot of variation there. Also, a lot of these studies, a lot of these systematic reviews rather, mix studies that involve e-prescribing with clinical decision support, along with studies that involve e-prescribing without good clinical decision support. And generally, the more advanced the CDS, the better results you have. So our feeling is that without the clinical decision support, e-prescribing may not do much more than solve the physician handwriting problem. So here's a systematic review that was done in 2008 that found that CPOE was associated with a 66% reduction in prescribing errors. So all right, that's pretty substantial. Only 3 out of the 18 studies, however, found reductions in adverse drug events, so more adverse drug reaction type things as opposed to errors. One thing they did note, though, is that wrong drug errors were not necessarily reduced with e-prescribing. So in some ways, you have to question whether we've simply traded one problem for another in this respect. Have we traded the physician handwriting problem and pharmacists misreading that and dispensing the wrong drug for the problem of choosing the wrong drug from a pick list where drugs are ordered by generally in alphabetic order? So another review using slightly different rules and a different combination of studies found significant relative risk reductions in medication errors and ADEs. But what I found interesting about this case is the extreme variation in the improvements that they found. So 23 studies showed anywhere from 13% to almost total relative risk reduction. That kind of variation, again, points to that, if you've seen one implementation, you've seen one. And it also, I think, points to the need to evaluate EHRs and EHR safety at the level of individual institutions, not sort of en masse. It also points to the importance of how the EHR is implemented being as important, if not more important, than sort of the underlying software that comes out of the box. So I'll turn now to computerized alerts. This is another area where a lot of studies have been done, not too many systematic reviews. But one study that looked at 230,000 drug safety alerts across thousands of physicians in multiple practices found that only about 6% of electronic prescriptions triggered an alert, at least within this group, which is not a whole lot. But the physicians rejected or ignored 9 out of 10 of the drug interaction alerts and 8 out of 10 of the allergy alerts. That's remarkable. What that says to me, from a human factors perspective, is that a lot of these alerts do little more than transfer the liability for a medication error from the hospital to the physician. Okay? If these alerts are not serving a clinical purpose, and I think this is evidence that many of them are not, that's something we need to work on. I've talked to the CMIOs at hospitals that I consider to be among the best hospitals in the country, and their results are similar to this. They have alert override rates in the 90%. One hospital, I'll share this anecdote with you, got a physician committee together. They worked with their formulary committee, and they came up with, they wanted to come up with a list of alerts that they could remove from their system. Now, out of the thousands of alerts that are probably operating in your CPOE systems, they found, I think, 50 that they were comfortable eliminating. And when they did, they got their alert override rate to go from about 96% down to about, I think, 89. Real marginal reduction. So there's a lot of work to be done here. I'll contrast that. I want to contrast this study with the one that follows it. These are individual hospital studies. This one is a narrow one that looked at could they get a CPOE intervention to change the way physicians prescribe drugs for patients with renal insufficiency. And this is a study that actually had negative results. They found that their intervention was not effective. The alerts did not significantly impact prescribing errors. There were still around 1/5 of all prescriptions were in error. And what's interesting here is that during the intervention, the senior physicians, the experienced ones, actually made more errors after the intervention than before the intervention, okay? And they also made more errors than the residents did. One of the explanations that the researchers hypothesized in this case as to why that was the result they found was that the design of their intervention they think led to this result, in that what they did was they basically had sort of a passive suggestion that came up that basically had a dose conversion table, and they were sort of relying on the physicians to recalculate their own doses. In contrast, some of the other studies that have looked at that same problem of patients with renal insufficiency, the alerts were more interruptive, and the information that was presented to the physician, their doses were recalculated for them. Okay, and that's important, and I think bears on this next study. Unrelated, but an observational study of 31 primary care practices, 700 and some physicians, where they went from a one-size-fits-all alerting system to a tiered alerting system. So basically, low-level alerts were non-interruptive, okay, and they would sort of appear off to the side, whereas those that were more serious, they either needed the physician to explain, why are you overriding this alert? There had to be a rationale for it that was documented. And in some cases, if someone was trying to prescribe, a lethal dose of heparin or something, it would be a hard stop and they wouldn't be able to do it. And what they found was they got their alert override rate for the serious alerts quite high, 67%. So what I'm trying to demonstrate in contrasting these two studies is the use of human factors principles in the design of clinical decision support systems. Right? This is more of what we have to do. When we look at the evidence for sort of an overall beneficial EHR effect, now I'm not talking about an overall effect on efficiency, I'm not talking about an overall effect on satisfaction or whatnot, but specifically on safety and quality. There are a couple of studies that bear on this. One is a study that looked at what's known as the core measures. Do people who show up in the ED get AMI prophylaxis within 30 minutes? The skip measures, many of which relate to infections. And basically that study found no effect. EHRs are associated with reduced HAIs in some cases, but not post-op hemorrhage, hematoma, or post-op PE or DVT. These were some of the ARC patient safety indicators that were looked at. And those PSIs are based off of billing data, which, as I'm sure a lot of you know, have serious quality problems. And lastly, HEDIS measures, basically looking at a lot of preventive care and patients' experience of care. Again, found no effect with EHR. So the overriding message being that when we look in the places that we usually look for information about improvements in safety and quality, we don't find an overall effect of EMR adoption. Some information is beginning to come out, though, about med mal claims. And this is work that's being done from CRICO, the Harvard insurance captive. And basically, when they look at their closed claims, they're starting to see evidence of med mal claims reduction following EMR adoption. Now, this is a early study result. The follow-up period was fairly short on this study, so there are some limitations to this, but this is a step in the right direction. So before I get into the data, I'll just make a brief word about patient safety organizations. Some of you may be familiar with this already. But basically in 2005, Congress passed a law, and President Bush signed into law, with the Patient Safety and Quality Improvement Act of 2005. And one of the things that this law did was to create a program for organizations like mine to become certified by HHS as patient safety organizations. Now, we've been working in patient safety for as long as our organizations existed, but this sort of codified a protected space in which providers can share information about safety without that information being disclosable or usable in legal proceedings. And what we're seeing is, a lot of hospitals and a lot of state hospital associations are setting up patient safety organizations, and we work with many of them, that are aggregating patient safety data from the reporting systems that exist within your institutions individually. And by aggregating that data, we're able to see things that an individual hospital won't see. There's all kinds of variations in between institutions about what people consider reportable, what kinds of things people report, and the volume of reporting. The information that we're collecting is not so good for generating incident statistics. I don't want to oversell this, but what these data are good for is pointing out all the ways in which different clinical processes can break down, and that's what we're trying to do with it. So before I talk about our data, there have been data published out of FDA. So this was a study that was done back in, just published in 2012 actually, but done I think a year or two ago, where some researchers extracted data from FDA's MAUDE system. This is the medical device reporting system that FDA has, and it found that only 0.1% of the reports in MAUDE they could identify as having a health IT component. So that's a very, very small percentage. That probably understates the magnitude of the problem, however, because health IT currently is not really regulated. So these are the things that, these are the reports that people who thought health IT was regulated and is considered a medical device were submitting to FDA. So they found that of the reports that they were looked at that were HIT related, 11% involved patient harm, and they identified 4 deaths that they attributed to health IT. Now, what's interesting is they classified these reports by things that were primarily IT or machine related or software related, those that were essentially human errors, and those that were sort of at the human-computer interface. And what they found was that 96% of them were machine related, 4% were at the human-computer interface, and none were simply pure human error problems. Our data, on the other hand, tells the exact opposite story. So these are reports that are submitted to hospitals' internal reporting systems that are then aggregated at patient safety organizations like ECRI Institute. And what we've found is that by and large, the reports that the clinicians are making are much more about the human-computer interface and what you would probably consider user error. But even those user error problems are useful to look at in terms of looking at human factors and usability of the systems that we put in place. So I realize this chart is probably too small for those of you in the back to read. Hopefully it's in your handouts. But all I wanted to point out about it was that most of the categories that we came up with in this early analysis, which will be updated in a report we have coming out later this year, is this is an analysis that we did of only 230 event reports. We've got, I think, well over 1,000 related reports now. But basically, in this early categorization, we found that only a handful of categories of the reports that we were seeing were things that we felt were unique to health IT that did not have analogs in the paper reporting world. So the top category, for example, was delay or failure in entering a physician order. Clearly, that's not a fault of the software. That's a human issue. However, the second category, those with the asterisks on this chart are the ones that we felt were unique to health IT. The second category is discrepancy between the EHR and the paper chart, where systems were being run in tandem. And I'll talk a little bit more about these hybrid systems in a bit. So to give you some examples of these, failure to act on charted information. So this is a patient who was known to be heparin allergic who was given Lovenox. So that order went through not only the CPOE system without being caught, but also the pharmacy system. Heparin being a high alert med is an obvious candidate for an alert. But what's interesting about this, while this report is clearly something that also happens in the paper EHR world, what's interesting to look at it, I think, from your perspective is, A, why did this get through two possible alerting systems without being flagged? Or second, was the heparin allergy information not flowing between systems? And is that why maybe you do have an alert for heparin, but it wasn't caught because the allergy information is not being transferred appropriately? So you can still learn from these reports even when they are primarily problems that existed with paper charts. So here's another interesting case. This is a case of a woman who was admitted to the hospital, and someone in admissions accidentally tied her record to her husband's, who had been in that hospital previously and who is now deceased. So, all right, it might not be that big a deal. You might think, all right, we got her date of birth wrong, and but there was her spouse's MRI was showing up as hers, and her medical history actually showed the details of admissions or from her dead husband's prior admissions. They were showing up as hers. So this is, we have patient identification problems in the paper chart world too. So this isn't unique to health IT, but the mechanism of the error here is clearly IT related. And here's an example of one that we sort of would consider a pure health IT problem, where an order was automatically discontinued. Okay, so in paper charts, orders don't discontinue themselves without human intervention. So I mentioned before that most of the problems that we're seeing are things that existed with paper charts too, and just the EHR has sort of just transferred the mechanism of error. And these are all things I'm sure you're familiar with on a day-to-day basis. These technical problems that are new and unique to health IT. Some of the other unique health IT problems are legal, and they're risk management issues. Basically, failure to act on information timely. Now it's possible for us to tell when a lab result was reviewed by somebody, and if they fail to act on it, then they can't claim the defense that, oh, I didn't see it, or I couldn't make sense of it. One of the other things that we're interested in looking at is whether there is a marginal risk associated with actively rejecting evidence-based guidelines that are codified in your clinical decision support rules compared to physicians simply not following the guidelines in general. Does it make a difference if there's some sort of standard of care that isn't given to me if the physician was actually presented with the opportunity to catch that omission and chooses not to do it? So one of the things that people are doing, I think, to head this off is where alerts are overridden, where guidelines are not being followed, is requiring some documentation to that effect. Something else that's changed with health IT is that the scale of problems is different, right? Think of the Cerner outage from earlier this summer. No longer is it just one patient record that goes missing. Now we can get rid of them all at once. We're also aware of some selected cases of mass data loss. There was one hospital that basically lost several years' worth of archived records that were being stored at a cloud vendor. And there were not good systems in place to periodically test the ability to restore those archived studies from backup. So that's something you need to look at your vendor contracts for, is to make clear who's responsible for those things. Another interesting example, the VA, this is going back a few years, the VA actually had a problem where medication orders were showing up in the wrong patient's chart, but it was happening intermittently. So the order would appear in a chart and then disappear. So they actually had trouble reproducing the problem. The way they discovered it was that a drug for erectile dysfunction showed up in a female vet's chart. Interesting case. So some of the data that we're about to publish from the Patient Safety Authority, I'm giving you a bit of a preview of it here, is we looked at the patient safety database we've been running in the state of Pennsylvania since 2004. And over the course of those years, you can see the adoption of health IT. The graph is pretty interesting. But even though we did not really start out trying to collect health IT reports, and there's nothing in our event type taxonomy of, I think we have 230 different sort of event type codes. They are not related to health IT. We actually mined the free text to identify health IT related reports. And we found about 8,000 in which the EHR was mentioned. We took a random sample of those to review manually because 8,000 was a little much to read manually. And what we had to do was sort of disambiguate the reports that sort of just mentioned the EHR in passing. Mrs. McGillicuddy fell and I documented it in the EHR, from those that are clearly an HIT problem. And we tagged we tagged our reports with the same classification system that was used in the FDA study that I mentioned earlier. And we did add to that taxonomy a bit, but these are the initial results on the 20% random sample, but we basically used a machine learning algorithm to review the rest, and then sort of captured those, we used the machine learning algorithm to separate the EMR incidental reports from the EMR focused reports and continued to manually review and classify those. So what we found, again, similar to the data from ECRI, is that the wrong input or failing to update a clinical record, we're actually at the top in terms of the types of reported events. Although software issues and system configuration issues are at number 3. And I'll dive into more detail on those in a second. And this classification system also looks at some of the contributing factors. And basically, sort of the top 2 categories we found were default values were causing trouble, and paper versus EHR mismatch, that hybrid paper and electronic system. So in terms of entry errors, almost 800 reports included either someone put in the wrong data or they put it in the wrong chart, or a failure to enter data. So in this case, they had a pharmacy tech that actually processed an order on the wrong patient. There was some sharing of user IDs and passwords that should make the CIOs cringe. But in clinical decision support, ideally, is supposed to prevent this sort of thing. But one of the issues you have is, as I'm sure you know, is that when the clinical decision support is presented to someone who is not the clinician decision maker, it's going to be less effective. So that's, we still have reports of physicians who are getting nurses to enter their orders for them, and the nurses are doing that as a chore, not with their critical thinking hat on. So here's an IT issue, system configuration and design. Basically, this is there was a disconnect between the reagent that was supposed to be used in a lab test in the CPOE compared to the reagent that was supposed to be used according to the instructions in the lab system. So, you've got patients having tests ordered that then, if they're not caught, are going to be done in the wrong way and have an incorrect result potentially. And a lot of the vast majority of the system configuration, the vast majority of the system integration issues that we've had reported were specifically related to incompatible system configurations among networked systems. And I mentioned before about default values. Right, here's a case where a resident went in and ordered the default value of a drug rather than the one the physician described, and actually the patient became unresponsive and hypotensive as a result. And hybrid systems, okay, so this is the paper and electronic systems being run in tandem, which actually may be less safe than either system running by itself. So the problems here is that if you're running both systems in parallel, which I know people are doing that to sort of ease the pain of transition, but it actually may be causing more problems than it helps. There's no one source of truth for the clinician. You've got nurses running back and forth. They think they know what's going on. They think they have situational awareness, and they don't, because there's information in the other source besides the one that they looked at that they're not taking into account. So to wrap up a little bit here, I want to close by talking about how do we go about evaluating our health IT and the EHR. So hopefully a lot of you are familiar with this graph. This is a concept that is being popularized by Dean Sittig from Baylor Health and Hardeep Singh. Basically, they're two of the national leading experts on safety and health IT. And the point that they're trying to make is that you have to evaluate health IT as a socio-technical system. It's not just about the hardware and software, though that is one of the nodes in this graph, but it's also about the organizational policies and procedures. It's also about the clinical content and the workflow. It's about the human-computer interface. You have to take these things into account in order for the work that you're doing to pay off. So I'm not going to have time to go through all 8 of those, but I'll just touch on a couple of these. So looking at the organizational policies and procedures and culture, one of the things I wanted to do is to try to come up with some things that maybe you could take back and integrate into your programs. One of the things that we encourage people to do is to make sure that there is a mechanism for communication between the IT committee and the patient safety committee. A lot of the patient safety officers in your institution they're former risk managers. Generally, risk managers are coming up through nursing tracks. They're coming up through legal tracks. They're not IT experts necessarily. So if there's good communication between IT and patient safety, I think that's one area that we need to focus on. One of the other questions that you can ask yourself is, what are the mechanisms and how easy do I make it for people to report the problems that they're having? I mean, I'm sure you're all running help desks, but when does a help desk issue get escalated to a safety issue? Putting it in a different context is going to dictate a different response. Are you evaluating the help desk issues not only for the frequency and the user annoyance factor, but also for the potential severity? Not just, did this particular thing that's getting reported wind up injuring a patient, but if this sort of thing is happening throughout my system and it's happening every day, what is the probability that somebody else is going to be affected by this and result in a bad clinical outcome? In terms of clinical content, the life or the shelf life of medical knowledge is depressingly brief. And constantly needs to be updated. So all the order sets that you have in your systems, all the clinical alerts in your system, what's the process that you have for not only documenting those alerts and how they're operating and what's triggering them, but also what's the process for reviewing them periodically every couple of years to determine whether they need to be updated or in some cases sunsetted. Also on the clinical content, you need to ask yourself, is the clinical content of my CPOE being presented to the right individuals, right? So if there's not an organizational policy in place that requires the prescriber or the decision maker to enter their own orders, How effective is the clinical decision support going to be? You also have sources of data to produce new clinical content available to you. So have you ever reviewed the logs from your pharmacy intervention program to look for high alert drugs being prescribed that require a pharmacist to have their critical thinking hat on and catch manually rather than have the system catch those? Your help desk logs. Again, are they reviewed not from an IT perspective, but from a safety perspective and prioritized appropriately? Hardware and software infrastructure. So this is the stuff that everybody thinks about when they think about IT. This is system uptime. To what extent is that being monitored? To what extent are workstations outmoded and the capabilities of workstations being outpaced by the complexity of your clinical systems? What are the processes that you have in place for testing your backup solution? How frequently are you trying to restore things from backup? So I'll end with this quote, and this is just a week or two ago in the Wall Street Journal. Some of you may have seen this. Stephen Samurai and Ross Koppel basically did, I think it was an op-ed piece, and I'll read this to you. Lobbyists promised that these technologies would make medical administration more efficient and lower medical costs by up to $100 billion annually. An extensive new study indicates that the caution is justified. The savings turn out to be chimerical. The software is generally clunky, frustrating, user-unfriendly, and inefficient. This is the part where you're all supposed to boo. All right, but what did they, oops, where'd I go? But what do they get right? All right, I think one thing that they get right is their economic analysis. They're right in that the savings that the EHR was sold on hasn't been produced, at least not yet. But it might have been necessary in order to get buy-in of the legislatures for the ARA incentives and to get the hospital CEOs, some of them, to buy into the EHR. We may have needed to make that ROI argument, but not everything can be justified in economic terms. I think there's another way of framing this discussion, which is to say the investment that we're making in health IT is an investment in infrastructure. We don't calculate the ROI of the U.S. highway system. No one asks what's the ROI on a college education. What's the ROI on the internet, right? It's an infrastructure investment. It makes other things possible. The other thing that I think Samurai and Koppel get right is clinicians' frustration with the current state of the EHR. And it's a lot of them are the technophobes, but it's not exclusively the technophobes. And there are some physicians that I know who are highly tech savvy, who recognize the limitations of the systems that we currently have in place, and they see how much opportunity there is for improvement. But what they get right in that statement that I read is the level of frustration among clinicians. They feel like they've become data entry clerks and that they are serving the computer rather than the other way around. And but let me tell you what I think that means, and hopefully this will end on a good note. It's not often that I can work a quote from George Carlin into a talk that I do for work, but I once heard him do an interview where he said, if you scratch a cynic, underneath you're going to find a frustrated idealist. That means that this frustration you're probably experiencing from the clinicians and the frustration that I think they captured in this op-ed piece means that they share the same vision for this stuff that you do. Right? They know its potential. And when I look at the agenda on your meeting, clearly these are the things you're all working on, and I'm excited to learn from you today about what you're doing to accomplish these objectives. So that we're going to eventually overcome these short-term problems and get to the real payoff, which is what everybody dreams about with health IT. When my mother gets admitted to the hospital, the EHR should be able to calculate what's her risk of developing a pressure ulcer, and it should prompt the right prophylactic measures and the right nursing care. It should be able to calculate her risk of falling and prompt the right nursing interventions, based not only on the history that she gives you when she shows up, but also based on her prior medical history about the medications that she's on when she's at home, not just in the hospital. That's the dream for this stuff. The clinicians want you to relieve them of the burden of documentation. Eventually, we're going to get to the point where a lot of the documentation is going to be produced simply as a byproduct of the care that's being delivered. And that's going to be the real payoff for this. So I'll end on that note and just say I'm excited to hear the rest of your presentations today.